Hi everybody, I am Dr. Pradeep Kumar Shenoy, consultant rheumatologist at Amrita Multispecialty Clinic, Kattavaram, Mangalore. This is the first rheumatology clinic of Dakshina Kannada and Udupi district of Karnataka. In this video, we will look into osteoarthritis further. We will keep knee as the prototype of the synovial joint, as it has got all the components of synovial joints and it is involved in primary osteoarthritis as well as other inflammatory arthritis. Let us look into the symptom of a person who is having osteoarthritis of the knees. There will be early morning stiffness, which will typically last between 45 to 30 minutes. And a person with osteoarthritis of the knees, while walking, he will have more pain, and while taking rest, the pain will be less. After sitting for a prolonged number of time, when the patient begins to get up, he or she will feel a little bit of stiffness to get up. This is called as gelling. This happens because of the edema of the cartilage. Now, we will look into two nutraceuticals which are used to treat primary osteoarthritis. They are glucosamine and chondroitin sulfate. Glucosamine is a glycosaminoglycan which is the primary component of the extracellular matrix of the cartilage. Nutraceutically, glucosamine is extracted from the lobster and the crab shells. So somebody is having a shellfish allergy might develop reaction to glucosamine, but no worries. Most purified form of glucosamine has been marketed, and in the laboratory, similar chemical with similar nutraceutical bar pharmaceutical effect is being manufactured. So currently we are going for newer molecules. Coming to chondroitin sulfate, it's an integral part of the cartilage which keeps the cartilage hydrated. During the weight bearing, it leaves water, and during unloading, it absorbs water and keeps the cartilage hydrated. Nutraceutical source of chondroitin sulfate is bovine tracheal cartilage. In some patients, chondroitin sulfate can produce anticoagulation. This is because of the glucuronic acid residues of the chondroitin sulfates can undergo full O-sulfonation and structural changes, conformational changes. This can produce anticoagulation in some patients. Moreover, it can produce, virtually it can leave a patient with a potential development of mad cow disease or Creutzfeldt-Jakob disease. But again, most purified form of chondroitin sulfate has been marketed, and similar chemical with similar nutraceutical bar pharmaceutical effect is being manufactured in the laboratory. Coming to viscosupplementation, mainly hyaluronic acid is used to give viscosupplementation. Hyaluronic acid or hyaluronan is a major component of the synovial fluid. It is also a glycosaminoglycan. It has got two effects. In the low weight bearing, it is a viscous lubricant, and in the high weight bearing, it is a shock bearing agent. So, coming to the intra-articular injection of hyaluronic acid, if there is a knee joint effusion, it has to be tapped to dryness, then only we will get the maximum benefit of viscosupplementation. Hyaluronic acid has got majorly three action in the joint cavity. It has got a chondroprotective effect where it increases the synthesis of a proteoglycan in the cartilage. It has got a anti-nociceptive effect. It interacts with the afferent nerve endings in the medial compartment of the knee joint. It interacts with the neuropeptides like substance P and calcitonin G related peptide, as well as other neuropeptides, and it produces analgesic effect. And it also acts as an anti-inflammatory agent because it acts as a scavenger sink for inflammatory mediators. These are the three effects of viscosupplementation. But this should be done in early stages of osteoarthritis, and there is a different protocol for depending upon the pharmaceutical preparation. Usually it is given weekly for 3 to 5 weeks, but always you can use different preparations, and reading the literature, based upon the literature you can give different protocol. We can use different protocol, and this can be tried every 6 months. So long-term effects of viscosupplementation is not well known, but this can be tried in patients who are suffering. Coming to the topical preparation of NSAIDs, NSAIDs has got other components along with it. In the topical application like methyl salicylate, menthol, and capsaicin, etc., it should be used for 6 to 12 weeks to extract maximum benefit. Because, as I've already mentioned, the afferent nerve endings in the medial compartment of the knee has got neuropeptides. Capsaicin will take 6 to 12 weeks to deplete the inflammatory mediators or neuropeptides from the joint cavity. So, to declare topical preparation as not successful, it should be used for 6 to 12 weeks. Coming to the innervation of the hip and the knee joint, hip joint is innervated by the femoral obturator and saphenous nerve. Same nerve innervates the knee joint as well. So the pain in the hip joint can radiate to the knee joint. So if there is osteoarthritis of the hip joint and the knee joint together, the hip joint is operated first. As a rheumatologist, my explanation was that if there is a pathology which causes pain in the knee joint, if there is a pathology in the hip joint which causes pain in the knee joint, once that pathology is removed, knee joint can be independently assessed. But orthopedician's take is that once the hip joint is replaced, very next day patient can be made to walk and the rehabilitation is very easy. So after replacing the knee, after 2 to 3 months, the knee can be replaced. Coming to the total knee replacement of both the knees together, if the patient is, this can be done. This decreases the number of stay of hospital, and this also decreases the threat of going through anesthesia twice. Coming to usage of NSAIDs per se, long-acting anti-inflammatory drugs, non-steroidal anti-inflammatory drug, a patient with osteoarthritis of the knee can use maximum of 5 painkillers per month. This is what I picked up from a slide which was projected in the EULAR conference. My friend shared the slide with me. Up to maximum 5 painkillers can be used for knee osteoarthritis. But of course, there are other modalities, as I told in the last lecture. There can be physical therapies, IFT, TENS, etc. to relieve the pain. And coming to the knee joint, I told that it can be involved in primary osteoarthritis and other inflammatory arthritis. So if it is involved in rheumatoid arthritis, both medial and lateral tibiofemoral compartment will be reduced. But if it is involved in primary osteoarthritis, only the medial tibiofemoral component will be reduced. So this video has been shot because of many queries from my patients as they have watched my previous video. So I hope I have answered most of their questions. Thank you. Thanks a lot.